Let me introduce Jennifer Holtz. We're pleased to have her join us this afternoon. Jennifer Holtz holds a master's degree in public and human service and health administration from Minnesota State University Moorhead and a bachelor's degree in psychology. She has nearly 20 years of professional experience working in behavioral health, as well as personal experience with recovery from the perspective of a family member and a friend. Jennifer believes in a holistic, self-determined, recovery-focused philosophy of care that supports people with substance use disorders and mental health conditions to build meaningful connections within their community. In her spare time, Jennifer enjoys reading, hiking, volleyball, live music, and spending time with her family and friends. So welcome, Jennifer. Thank you very much.
All right. Well, thank you. Thank you very much for inviting me to speak here. I was a little bit confused. I was trying to get started on time, so I was probably talking to myself, going through the slides a little earlier. So if anybody was in the breakout room and could hear me, I apologize. I'm going to start over a little bit, but we will move through this quickly. If there are any questions or feedback, I want this to be as interactive as possible. So I am happy to introduce or answer any questions along the way. So please feel free. So I had already spoken with members that were already in the breakout room about First Link services. I'm not going to repeat that because I believe we already had a number of people in the room that were listening to that. So I had just finished speaking about First Link, what kind of general services we provide. You do have access to the handout, to the PowerPoint presentation by handout. So if you have any other questions about First Link, feel free to speak up. Otherwise, I am going to jump right into the Care and Support Program. All right, so the Care and Support Program has evolved over the last few years and quite dramatically evolved in the last year. Some of you who are familiar with First Link or have partnered with us may be familiar with the Suicide Support Follow-Up Program. This was a program that was started about 8 or 9 years ago through a SAMHSA grant, and then later the North Dakota Department of Health helped fund after the grant ended. Currently, we are being supported by partnering clinics and hospitals. And what this program provides is some critical support and timely access to services for individuals who may be at risk of suicide or death by substance use, by high-risk substance use. So when this program was started, originally it was really meant to support the emotional and physical safety of people at risk for suicide. And it was offered through some memorandums of understanding we developed, or partnerships we developed with specific clinics and hospitals. I believe our very first partnering hospital was Alltrue. That was through the Columbia Research Study with the SAMHSA grant that we had. Later, we added multiple other clinics and hospitals, and right now I think we have over 24 and about 5 active clinics and hospitals that refer to us every month. People can also get referred through the 211 or the National Suicide Prevention Hotline that I was talking about a little bit earlier. So the other component of what's now called the Care and Support Program is helping people navigate substance use treatment. This was started as a pilot project back in 2016. The Fargo, Moorhead, West Fargo communities joined together to address the opioid epidemic, and they established a Mayor's Blue Ribbon Commission on Addiction. That commission determined a number of strategies based on early intervention, treatment, and recovery support. And the Community Addiction Navigator was developed, or that program was conceived within the Mayor's Blue Ribbon Commission as an early intervention or intervention support. The primary components of that program were to develop partnerships with drug and alcohol treatment providers, have access to real-time information on availability, and in-depth knowledge of insurance and other barriers that impact an individual's ability to access treatment. So we really worked hard to enhance coordination. We learned a lot of lessons from that pilot project, and it later expanded outside of Cass and Clay counties so that we included all of North Dakota as part of our 211 catchment area, and also our NSPL area, which covers all of North Dakota and 19 counties in Minnesota. So that program, we learned a lot of really valuable lessons, including providing assertive WARM transfers, doing follow-up, and evaluating other barriers to treatment. So there's a number of factors that can impact a person's desire or ability to access behavioral health. And so when that pilot ended and we took the I just realized my screen. I am sorry. I'm screen. So when that pilot project ended, we realized that we couldn't just end that level of support. We were really providing critical access to treatment and recovery support 24 hours a day to people who were calling in through the helpline. And also many health providers were contacting us to consult or referring patients for that support as well. So last year, we decided to streamline these programs and take, the evidence-based interventions we learned from the suicide program and all of the wonderful information and feedback we got from the communities we served through the Addiction Navigator, and we combined it. And so now we offer, so we call it Care and Support. And, this again, there's some critical factors of these programs, which are to, number one, keep people safe, support the safety and emotional well-being of people who are maybe at risk for suicide or at risk of a substance-related death, whether that's intentional or accidental. Enhancing access and promoting adherence to treatment and aftercare. So whether that's post-discharge from a psychiatric or a medical facility, making sure people are getting connected to the appropriate services, that they're following their aftercare, taking their medications, and really just addressing a lot of social determinants of health. By utilizing our community resource directory, we are able to connect people to local resources and support and explore maybe some potential solutions that hadn't been thought of before. We really strive to empower and motivate every individual that's referred to us to make the most of the resources available to them, and just recognizing what kind of supports are available in their community, and encouraging that safety or harm reduction plan, encouraging them to use or to build up a natural support network. This program helps reduce gaps in services. So healthcare providers, one of the number one concerns we hear over and over and over again is that healthcare providers, when they are discharging a patient who's had a psychiatric crisis or a serious behavioral health emergency, once they're stable, oftentimes, especially in our rural healthcare settings, there is limited access to services and there's a long wait. So this really helps fill the gap, providing some ongoing support to individuals while they are waiting to get engaged with their treatment or their aftercare. We regularly review their harm reduction and safety plan, collaborating with their behavioral health or medical providers as it's appropriate. Our goal is never to interfere or intervene. The individuals that the call specialists trained to do these follow-up calls are not clinicians or counselors. So our job is not to diagnose or counsel, but really to provide support and explore, some resources or strategies to strengthen a person's own plan to keep them safe. What does caring contacts look like? So I mentioned early on in the program that this was an evidence-based, it was a study out of Columbia through a grant from SAMHSA. And so a major component of that program was what's called caring cards or caring contact. And so we have adapted this for the care and support program. So every individual that provides a mailing address or a physical address gets mailed a card. We handwrite those cards. If we don't have a mailing address and we reach them for that initial follow-up, we will ask them if they're okay with texting, and we can send out reminders, we can schedule texts if they don't have their voicemail set up or they don't like to receive calls, we can schedule texts for follow-up. The phone calls that we make tend to be brief, but they are structured. We are intentional about assessing for safety. We're intentional about assessing for a broader range of needs and getting people connected to services in the community. If an individual happens to be in crisis, we will, our call specialists are highly trained in applied suicide intervention skills, Safe Talk, which is a gatekeeper training that we offer, and mental health first aid. So we really, we focus on the needs of the individual and what kind of support they need in terms of staying safe and connecting with their providers or their natural support system. This is an example I like to share of one of our earlier caring cards. They don't look much different from this. They're pretty similar to this, but it's a handwritten note. We include sort of a little encouraging or inspiring picture in there. And then we also include our calling card and usually a magnet too, if we have a magnet. So I already talked about what follow-up consists of, what we're looking for, how those calls are structured. I will say that every person, whether they are referred by a partnering clinic or hospital or the helpline or suicide prevention lifeline, we make a minimum of 3 attempts to reach an individual and as many as 5 attempts for somebody who is at medium to high risk for death by suicide or a substance-related death. So follow-up has become a really commonly used practice in all areas of healthcare. I think actually maybe behavioral health is one of the slower areas of health to catch on. And that might be in part due to silos or difficulties coordinating care that the behavioral health sector really still needs to work on addressing. But for a long time, hospitals and clinics have been providing follow-up for surgery or for other, medication follow-up, things like that. So behavioral health is really no different. We're going to make that first attempt within 24 hours of their discharge. And then subsequent attempts are usually spaced about 2 to 3 days apart. We also vary the time. So one thing that can be a challenge for hospitals is having the staff available to do those calls. When you partner with a crisis center like FirstLink, since we are a 24-hour facility and we have all of our call specialists are trained to make these calls, we can vary these calls. We even have individuals that work, third shift or have odd hours or have sleep disruptions that prefer calls, very early in the morning or late at night, and we can accommodate that. Most of our calls are made between 8 a.m. and 8 p.m. We have a 60%, actually a little more than 60% reach rate, which is phenomenal. I don't have any specific research to share with you, but just anecdotally, when I talk with other healthcare providers who do their own follow-up, theirs is typically more like 30%. So we have a terrific reach rate. We also have about around 65% of the patients or individuals referred will accept ongoing follow-up support. And we schedule those calls when it's convenient for the person. It can be every week. It can be every couple of weeks. We encourage them to call in for support in between calls if they need to. When, documentation and complying with HIPAA regulations is always at the forefront of my responsibilities as a program coordinator. So we want to be consistent in providing that service and making sure that we're collaborating with the partnering clinics and hospitals. We send out a monthly report, but we can accommodate other needs to providers as well. So if a provider prefers us to send a fax immediately upon contact, or if we aren't able to reach the person, we've done that before. We also have the ability through our electronic record system to send out an encrypted document. So we can actually, the documentation, the electronic documentation, we can send that out encrypted. So that's something that some providers really appreciate. Our collaborating clinics and hospitals, part of the memorandum of understanding that we have with them is to making sure that they're providing the appropriate information. That includes things like their address, so we can send carrying a card, but also information that's helpful for us to assess their adherence to their treatment. So if a referral was made to an outside clinic or agency, it's really helpful for us to know that. We assess for that as part of our post-discharge questionnaire. So if somebody isn't sure, we'll encourage them to, pull up your discharge paperwork if you got it from the hospital, and let's go through it together so that we can review that safety plan and that aftercare follow-up appointments. We also make an intentional effort to stay in regular contact with our partners. So our clinics and hospitals, we ask them to provide a primary point of contact as well as a secondary point of contact. And then we do regular follow-up to make sure that if there's been any turnover, that we're giving refresher orientation to clinics and hospitals. If there's been a change in staff and we have a new point of contact or some organizational restructuring, we are, that we're aware of that as well. So I do want to talk a little bit about why follow-up is important. And, I touched on this a little earlier as far as what kind of, the types of follow-up that have already been well practiced in many areas of health, and why this continues to be incredibly important for people with behavioral health conditions. People who are discharged from a psychiatric or an emergency care setting or other clinic or hospital setting, they are at the highest risk for completing a suicide or reattempting a suicide within their first week. And in fact, most people who do make a suicide attempt, there is documentation that they have been in contact with a primary care provider within 30 days. So many individuals who are at risk will have some sort of contact with their medical provider prior to an attempt. The other part of why follow-up is important is to encourage or enhance the likelihood that somebody's going to adhere or attend their aftercare. Studies tell us that as many as 70% of people who've attempted don't actually follow through with their first aftercare appointment or maintain treatment for more than a few sessions. So that's really, an important objective of the follow-up program. We we'll explore barriers to attendance because there are sometimes challenges that they may not, that their healthcare provider, the discharge coordinator may not be aware of. There might be issues with childcare, work, transportation. And those are all things that we rely on the 211 Community Resource Directory to help address so that we can eliminate those barriers and enhance a person's desire and likelihood to follow up with their care. Building motivation to commit to their recovery and aftercare plan is built into those structured phone calls as well. So this is sort of long-term benefits. There's also a cost benefit saving. So partnering again with a crisis center, a hospital, most hospitals in the area are implementing a zero suicide approach, or at least integrating a structured suicide prevention program into their medical care model. And so utilizing FirstLink as your crisis center as part of your aftercare and follow-up, and as just as a resource for patients, regardless of their needs, whether it's behavioral health related or not, can improve health outcomes in a number of areas when we're looking at social determinants of health. Here's some research that we have for caring letters and the caring cards. So there's a number of publications that are available. Again, this is all information that's available you can access the slide through the Dakota Conference website. I would share also that the contacts and the partnerships we developed through the Community Navigator program have really helped provide an additional arm of support for individuals. Suicide and substance use are directly correlated. And so when we are able to connect people to, whether it's a treatment program or a recovery support, whether that's peer support or faith-based support, whatever a person believes in, or whatever seems to work best for that person, we'll do our best to try to connect them to resources in their area, or give them some options for online or phone support if there aren't local meetings or services in their area. I've already talked a little bit about the unique opportunity crisis hotlines, crisis centers offer in providing that support, diverting inappropriate access with or diverting people to more appropriate resources, so that we're freeing up some of that inappropriate use of emergency departments or law enforcement, so that we can provide some intervention and crisis support. My name is Jennifer Holtz. I'm the coordinator for the Care and Support Program. Our community outreach position is currently open. Riley's no longer with us, but you are welcome to give Jennifer Illick, our Director of Helpline Operations, a call if you need more information or if you're interested in having First Link come and train on suicide prevention, gatekeeper training, or mental health first aid. Are there any questions?
Any questions for Jennifer?
I know I tend to go through these slides pretty quickly. So if there's anything we need to revisit, I'm certainly happy to go back and revisit some of the areas where I kind of passed by quickly. If I could leave you with a question or something to, did somebody have a question?
Doesn't look like it.
Okay. I'd really like to before we wrap this up, I'd really like to pose a question to all of you, which is who in your organization or maybe if you are a chief executive or a director or a program administrator, what strategies are you implementing in your healthcare organization to assess for risk and connect people with treatment? If you don't have or if you're not aware of assessment tools, I know a lot of healthcare providers are using like the PHQ and a number of other behavioral health assessment tools. But if you have questions about how to implement practical strategies within your organization, I'd be happy to answer some questions or share some ideas with you on that. I'd also like you to sort of pause for a moment and recognize that there are so many aspects of social determinants of health that can impact or be impacted by mental health or substance use and put people at risk for suicide. So there's so many complicating factors, including medical history, trauma, social and economic stability, support systems, all of those, so many of those factors. And so it may not be enough to simply evaluate somebody's mood or anxiety or depression. We may, if you're looking at implementing some other tools to assess or evaluate other social determinants of health, that can be a really important factor in assessing somebody's risk for suicide or a substance-related emergency. And many of you, I think, I grew up in a small town. I live in Fargo now, but I grew up in a small town. And in fact, when I was listening to Tammy Miller speak this morning, and she mentioned that her mom was an EMT, my mom was as well, in actually near Lakota. My mom was, they might have even worked together. My mom was on the voluntary ambulance with Michigan, North Dakota, which is right by Lakota. So, growing up in a small town, recognizing that people may not have a lot of awareness of resources, telehealth resources, other support networks, utilizing our community resource directory or calling. You can call with a patient, call the 211 line. We encourage people to call the NSPL line with patients if somebody's afraid or they're reluctant to reach out. So there's so many practical strategies you can implement, whether that's on an administrative level by training with Safe Talk for gatekeeper training, or implementing assessment tools and protocols to connect people with support and resources.
Any last opportunities for questions to enter in the chat, or if you would like to speak up and ask a question, please remember to fill out the test, the post-test evaluation, and also the sessions are recorded. So there's you probably wanted to catch your contact information. Maybe you didn't get it. There'll be an opportunity to view the slides or contact anybody on the Dakota Conference Planning Committee. We'll have ways to get in touch with all the presenters. So thank you very much, Jennifer. Great session. We appreciate your time and effort.